Welcome to an essential guide on emergency medical protocols for diabetic ketoacidosis, or DKA. We'll be summarizing the immediate management steps and key electrolyte replacement strategies for DKA. The primary goals of DKA management are restoring volume and perfusion, halting ketogenesis, slowly correcting hyperglycemia, and fixing electrolyte imbalances. The critical treatment process can be broken down into three main steps: fluid resuscitation, insulin therapy, and electrolyte replacement. The first critical step is intravenous fluid resuscitation to restore tissue perfusion and clear harmful ketones. Start by administering 0.9% normal saline at 15 to 20 milliliters per kilogram per hour during the first hour. Subsequent fluid choices depend on the patient's corrected serum sodium level. Use a formula to guide whether to switch to 0.45% or continue with 0.9% saline. When blood glucose drops below 200 to 250 milligrams per deciliter, switch the fluids to dextrose 5% with 0.45% saline to prevent hypoglycemia while maintaining the necessary insulin to clear ketones. Next, let's address insulin therapy. This is crucial for halting ketogenesis. Critical rule: never start insulin until the serum potassium level is known to be 3.3 MEQL or higher. Starting insulin with hypokalemia can cause lethal arrhythmias. Administer regular insulin as a continuous IV infusion at 0.1 units per kilogram per hour. An initial bolus is sometimes used, but the continuous infusion is key. The goal is to achieve a steady drop in blood glucose of 50 to 75 milligrams per deciliter per hour. The infusion rate can be doubled if the drop rate is too slow. Keep the IV insulin running continuously until the anion gap closes, which signals that ketogenesis has effectively stopped. The third key step is correcting electrolyte imbalances, especially potassium, which is severely depleted in DKA. If potassium is below 3.3 MEQL, you must hold the insulin and administer potassium replacement until levels are safe to begin insulin. If potassium is between 3.3 and 5.2 MEQL, start insulin and add potassium to the IV fluids to maintain safe levels. Routine bicarbonate use is not recommended due to associated risks. Reserve it only for severe acidemia, specifically pH below 6.9. Phosphate replacement is also not routine. Only replace if the patient has severe hypophosphatemia, cardiac dysfunction, or severe muscle weakness. Continuous monitoring is essential to confirm treatment effectiveness and determine when DKA has resolved. Monitor blood glucose every hour and electrolytes, pH, and anion gap every 2 to 4 hours until resolution. DKA resolution is confirmed when glucose is below 200, venous pH is above 7.3, and critically, the anion gap normalizes to 12 or less. Once resolution is confirmed and the patient can tolerate oral intake, transition them to a subcutaneous insulin regimen. Ensure a 1 to 2 hour overlap before discontinuing the IV drip to prevent rebound DKA.